Hey everybody, welcome back. Welcome back to the channel. My name is Quick, and today we have our guest lecturer back to go over another fracture conference with you. Much like the other fracture conference, we will be going over a template on how to read an x-ray and then let you practice it with regard to fractures of the lower extremity. Before I turn it over to the guest, I just wanted to take a second and thank all of you for your support. If you like the content and you want to help out the channel, consider subscribing, as that would help us reach other students through the YouTube algorithm. With that being said, I'm going to turn it over now to our guest. Enjoy.
All right, welcome back to Quick Steps. This is our series on orthopedic surgery for medical students. If you're a third-year medical student looking to get up to speed on what you will be asked on your away rotations, look no further. This is your introduction to the field. This is by no means comprehensive. However, we're going to go over the basics and what's very high yield and hopefully teach you how to read an x-ray. So today we're going to have lower extremity fracture conference. And we're going to go over how to read an x-ray first. So what you're going to do is you're going to say, this is your template right here. You're going to say this is an AP, lateral, mortise view, oblique of the ankle, radial shaft, etc., demonstrating a spiral oblique transverse fracture. All right, that is displaced or non-displaced. And so what we're going to look at also, if you can get them in time, will be any angulation you see, so any varus or valgus, along with any dorsal or volar displacement. And if you see a dislocation, you should change your read. Instead of saying it's a fracture, you're going to say it's a fractured dislocation. And remember, short and simple is a must. You're in a surgical subspecialty, brevity is key. Everybody needs to get to the OR. No one wants to hear a very, very long-winded discussion on what you think the fracture is. If you're running out of steam halfway through, that's fine. You can stop your read and just give the salient stuff, like what you think is most important, and whoever is pimping you or assessing your knowledge will follow up with their own questions and make sure that they can get to the bottom of whatever your understanding is. Alrighty, so let's start with our first one. So we got an 89-year-old female, past medical history of osteoporosis, status post fall from standing. I'll give you 5 seconds to read it, and we'll go from there. This is a femoral neck fracture, all right? And so the read is, this is an AP of the right hip demonstrating a non-displaced, incomplete femoral neck fracture that is valgus impacted. And this is deceptively sort of easy because it's a fracture you're going to see all the time in your rotations, but it's, in my opinion, sometimes it can be kind of tricky to even see the fracture sometimes. So you might see this and say, I don't see a fracture. If you have, so a little self-awareness helps. If you're in a fracture conference and they're showing you an x-ray, there is a fracture. Don't say there's no fracture. So just make up that you see one if you don't see one, and hopefully something will pop up. Let's go over the classification. So this is a Garden classification, all right? And so the Garden type is going to be Garden type 1, all right? Because I said the magic words, valgus impacted, right? So going back, so this is valgus impacted, and so sort of the way you can see the fracture is if you outline the cortex visually. So you look at it and you trace it with your eyes. The femoral head, the femoral neck, just trace the outline. Look for a break in that white line that's outlining the femoral head and the femoral neck. That's going to be sort of where you start looking in towards the medulla of the bone. And that'll sort of guide you towards where the fracture is. So if you do that here, you'll be able to see that there's like a little fracture that's on the femoral neck, and you follow it up, it kind of ends about, a few centimeters into the femoral neck. All right. So what do you guys want to do for this fracture, Garden type 1? You had a couple options. You can non-op it, depending on the frailty of the patient, or you can use cannulated screws. For the screw pattern, what would you guys want to do? All right, you want to do an inverted triangle. All right, and for your inverted triangle, which screw is most important and why? All right, it's going to be the inferior screw because it's going to go through the calcar, all right, which is the thickest part of the bone, all right, and that's usually posteromedial. For the inverted triangle, another thing I've been told and also I've seen is that the shape of it's not exactly like an equilateral triangle. It's sort of like an inverted L in terms of the shape that the screws will take on. So I've heard it described more of like an isosceles more so than anything else. And so What is the main complication of femoral neck fractures? This one's pretty easy, so it's AVN. All right, and so what's the blood supply to the femoral neck? Medial circumflex artery. But since this is ortho, I gotta ask you which branch of the medial circumflex. All right, and that's going to be the lateral epiphyseal branch off the MCA. All right, here's our next one, 73-year-old female. All right, brought in by EMS, status post fall from standing. Give you your 5 seconds. This is an intertrochanteric hip fracture. So this is an attempted AP of the left hip, demonstrating an intertrochanteric hip fracture that is completely displaced. You can say attempted AP, it's sort of like a tongue-in-cheek way of saying that this isn't the best x-ray. And a lot of times it's just due to the nature of the fracture itself. And so what additional view do you order when you have an IT fracture? You do a traction view, and that gives you a clearer x-ray. You'll notice my read isn't the most descriptive. I can't tell you if the lesser troch or the greater troch are on and off and various details, and that's for this reason. All right, so what determines treatment options for these types of fractures, IT fractures? It's whether or not the fracture is stable. All right, and so the next question obviously is what determines the stability of an IT fracture? All right, and we're looking for 4 things. We're looking for lateral wall blowout. We're looking for calcar comminution, reverse obliquity, and subtroch extension. I would say subtroch extension is probably one of the easiest ones to find, sort of in the heat of the moment when there's pressure on you to make this read. All you have to do is look for the lesser troch, and if you see the fracture going beneath it, boom, you're done. That's subtrochanteric extension, and you can call it unstable. In addition, reverse obliquity is another one. If you can get a traction view, you should be able to see the line going the opposite way. Calcar comminution, I've heard people say if the lesser troch is off, then that technically counts as calcar comminution. But I've heard some people say that that's also not true, but something you can keep in mind. All right, since the calcar is technically a posteromedial structure. All right, so what do you fix a stable IT fracture with? It'll be a sliding hip screw, which is called DHS, or a dynamic hip screw. You can either use DHS or you can use a cephalomedullary nail with a short nail. Okay, so cephalomedullary nail, so that's going to be, so cephalo is head, medullary is medulla, so that's going to go through the femoral neck and the femoral head. That's a nail you're going to put up into the femoral neck, so that's going towards acetabulum. All right, and then the other one is short nail, so that's your IMN, your intramedullary nail. That's going to go down into the femoral shaft towards the knee. And so the IM nail that's going towards the knee, that'll be short. However, what changes when you do an unstable IT fracture? All right, so you're going to have the long nail as your intramedullary nail this time. And what do you want to do before you fix an unstable intertroch fracture? There's one thing that you got to do that I didn't mention here yet. All right, so you want full length femur and knee x-rays, and that's because you're looking for any prior hardware. So if the patient had a total knee done, for instance, there's a stem, so you don't want to mess with that, right? So if you have a long nail, there's a chance it may contact the femoral portion of the total knee. Here's our next one, 55-year-old male, brought in by EMS, status post fall from height. So the patient was putting up Christmas lights when he fell off his ladder onto his left leg, which is now swollen and painful. I'll give you 5 seconds. All right, so this is a femoral shaft fracture. So the way you would read this is AP of the left femur, demonstrating a middle third oblique femoral shaft fracture that is displaced and shortened. The distal fragment is in varus. What do you want to do in the ED? Usual. So check if the fracture is open and closed. Neurovascular status, obviously you want to reduce it, and you're going to put it in a splint. And so for femoral shaft fractures, what's the main or the feared complication? All right, so blood loss, and how much blood can you actually hold in the thigh? So 1 to 1.5 liters. I remember from an EM course I took a while back, the attending was saying that you can hold all the blood in the human body can fit in both thighs. So humongous compartment. Okay, so back to ortho. So why is this fracture in varus? All right, it's because of the hip adductors. All right, so you have the adductor magnus. So always think of the deforming forces on your fragments when you look at fractures, especially for the femur. So what other injury are you concerned for? This is an important question. All right, femoral neck fracture. So ipsilateral femoral neck fracture. And so what's your definitive fixation for the femoral shaft? You can do a retrograde intramedullary nail, and this will be going from the bottom up. There's more questions I could have asked you. I didn't on the entry point for the intramedullary nail when you're going retrograde, but you can look those up. So when you have a femoral shaft with an ipsilateral femoral neck fracture, which of the two do you want to treat first? The answer would be femoral neck. Why is that? AVN risk is much higher. Here's our next one. 44-year-old male, brought in by EMS, status post motor vehicle accident, motorcycle versus stationary car. All right, patient has polytrauma as well, and so they're admitted to the ICU. I'll give you your 5 seconds. All right, this is a tibial plateau fracture. So this is an AP of the right knee demonstrating a displaced lateral split tibial plateau fracture with lateral depression. What's your classification for tibial plateaus? Okay, it's Schatzker. All right. And so what Schatzker type is this? All right, it's type 2 because it's a lateral split and depression. I go over mnemonics in a prior video for remembering the Schatzker classification. Be sure to check that out if you haven't yet. And to see the depression, I put 2 lines up here. So I'm using the medial tibial plateau here, sort of as like my benchmark, and you can see there's a gap between them. So the top line is a parallel line from the medial tibial plateau. The bottom line is a parallel line off the lateral tibial plateau, and the gap between them proves that this is that there's depression. All right, so for a type 2 Schatzker, what's the main complication? And that's a lateral meniscus tear. All right, so remember type 1 is just the split, and type 3 is the depression. But when you have a split and depression, think of the amount of displacement the lateral meniscus will be facing. That's sort of how I think about it. So that's why it's more likely to have the lateral meniscus tear in the Schatzker type 2. All right, so here's the disease course. So patient is admitted to the ICU and intubated. There is significant soft tissue injury and swelling in the right leg. So what's your best next step now? Patient still has the fracture. You want to put an X-fix on, right? Because I said there's significant soft tissue injury and there's swelling, all right? So if you have swelling, you won't be able to close the skin or the soft tissues after you finish the operation. So 2 weeks later, the patient successfully underwent several abdominal procedures to treat his severe polytrauma. Now today, his skin is soft and supple. All right, you can sort of guess what I'm getting at here. So what do you want to do now? Now you're going to do ORIF. All right, let's up the ante a bit. So let's keep going with these questions. So you're in the OR. What do you want to do to fix this fracture? All right, you're going to do plate and screws, right? And you have to restore the joint line. So you're going to use bone allograft. All right, so which bone allograft do you want to use? You're going to use calcium phosphate cement, all right? And so why do you want to use calcium phosphate cement specifically? All right, that's because it's got the highest compression strength of all the allografts. All right, think of the tibia, it's a weight-bearing bone, so definitely want compression. All right, and so when you're performing the bone graft, how do you determine when you're done? All right, you're going to use X-ray, fluoro obviously, because you're in the OR, and that whatever metaphyseal void you had, it'll resemble the surrounding bone. All right, so you're going to keep putting in bone graft until that void that you use to make the bone tamp, all right, that's going to look like the surrounding bone. So you won't be able to tell any difference. So that's your endpoint for how much bone graft you're going to put in. Here's our next one. This is particularly high yield if you're a medical student. So 28-year-old male, and we're going to take our time with this one. So brought in by EMS, status post, falling from a balcony during a party. I'll give you your time. I'll give you 10 seconds on this one. Try your best to make a read. All right, this is a bimalleolar fracture. And you can say again, attempted AP of the right ankle demonstrating a bimalleolar fracture. So it's bimal, right? So you can see here that there's a medial and lateral mal. So when you have these types of fractures, go mal by mal, saying what you see. Okay, so first we'll say the lateral malleolus is completely displaced with comminution of the proximal fragment. Then we'll say the medial malleolus has a transverse fracture that is completely displaced. All right, and then when you're doing ankle reads, you always want to make a comment about the talus. All right, so we can say here that the talus is also displaced laterally with significant tilt. All right, so this is sort of how you do your ankle reads. As a student, you will see a ton of ankle fractures. So the sooner you can get better at these, the better it'll be for you. So again, take your time, go with each mal, and just try your best. All right. So what do you want to do in the ED? Right. So the usual, right? Check if the fracture is open or closed. Check the neurovascular status of the patient. Reduce the fracture and splint it. All right. So now let's ask. So can you give me a classification for lateral malleolar fractures? All right, so it's the Weber classification. And so what Weber is this? All right, this is a type B, which is a syndesmotic fracture, a transsyndesmotic fracture. All right, so that's our lateral mal. So how about in general, what's the classification for ankle fractures? If you watched the prior video, then you'll definitely know this. So this is the Loggy-Hansen classification. All right, it's a behemoth of a classification system, so try your best. Which Loggy-Hansen is this one? Well, I did give you a hint. There's a type B, all right? So when you see a type B, you can usually say supination, external rotation. Technically, you would need the lateral for this one to see the direction of the fibular fracture, the lateral mal fracture. You're looking for AIPS, so the fracture pattern going anterior-inferior to posterior-superior, all right? And I remember that as Sir Apes, but I mentioned that in the mnemonics video, so feel free to check that out if you're looking for more mnemonics. I gave that one away, so you got a Weber B with the transverse medial mal. All right, so let's up the ante. So ankle is very high yield, so we're going to take our time here, like I said earlier. So what X-ray findings here suggest a syndesmotic injury? All right, so in general, it'll be decreased tibiofibular overlap, increased tib-fib clear space, and medial space widening. I put a star there because medial space widening doesn't exactly mean it's a syndesmosis injury. It's associated with syndesmosis injury. However, it's usually what's actually injured is something else. And so let's go one by one. So what's normal tib-fib overlap? All right, it'll be greater than 6 millimeters on the AP and greater than 1 millimeter on the mortise. So mortise has an O, so I think of O for 1. That's sort of how I kept that one straight. And I have an arrow here showing the tib-fib overlap. Next up, tibiofibular clear space. How are you going to measure that? Or what's the normal? All right, it'll be less than 6 millimeters. All right, and you're going to measure that 1 centimeter above the joint on both the AP and the mortise. So this is a number that does not change regardless of the view, all right, between AP and mortise. All right, and I have that up here as well. That will be the red arrow. And so what medial space widening is suggestive of syndesmotic injury? So what's the cutoff? Okay, so greater than 5 millimeters on a stress view. So for the medial mal, what do you guys want to do for definitive fixation? We're going to put 2 lag screws in, all right? And so for the lateral mal, what do you guys want to do? All right, plate and screw construct. And for the syndesmosis, 2 options. You can do the syndesmotic screw or a locking suture device. And what did you guys want to do for the talus? Well, what'll happen is after you perform the lateral mal ORIF, the talus will become reduced by that. Why is that? That's because the fibula serves as a lateral buttress to the talus. So reduce the fibula or the lateral mal, you get the talus for free. And here's a bonus read right here. So give this a shot. All right, so the black arrow here is an inner troch fracture. So what is the white arrow here? It's actually skin fold. All right. So if you follow that black line, you see that it extends above and below the ischium over there. So because of that, that's actually an artifact. So it's not actually a fracture. So make sure you don't get fooled by things like that. Okay. And in general, when you're reading your X-rays, just be calm and be cool. When you get that X-ray, I gave you guys 5 seconds. You can take your 5 seconds when you're getting asked on your rotations as well. People understand this isn't easy, especially if you're a third year trying to learn it for the first time. So take your sweet time. Take 5 seconds, 6 seconds. Just pace yourself and believe that you can do it. All right. And with that, we'll end this video. Make sure to like and subscribe and leave any comments for any questions. All right.